Hello, this is Dr. Vasquez. The following presentation was recorded live as a continuing education seminar for the medical school and the continuing education office affiliated with the University of Miami. The title of this presentation is Inflammation Dysfunction as the Cause of Chronic Inflammation, Allergy, and Autoimmunity. This presentation introduces and explores an extension of the autoimmune treatment protocol that I first published in 2006 in my book, Integrative Rheumatology. In this presentation, I introduce my updated treatment protocol, summarized by the FIND-SEX or the FIND-SET acronym, which I first introduced in March of 2012 in Paris, and which I later published in the book, Functional Immunology and Nutritional Immunomodulation, which again is an extension of and companion to my rheumatology textbook, Integrative Rheumatology. This audio and video had to undergo some extensive remastering in order to sync a new audio track to the video. I think you'll find this information extremely useful in your clinical management of chronic diseases. For additional follow-up information, please contact Biotics Research Corporation at bioticsresearch.com or me at optimalhealthresearch.com. This is Dr. Vasquez. Thank you, and we will now start the presentation. Good morning, everybody. Hope you're all doing well. This is Dr. Vasquez, and we're going to go through my information on some integrative treatments and kind of a functional medicine approach to treating these systemic autoimmune and inflammatory disorders. Some of this information that we're going to go through, particularly at the start of the presentation, was reviewed in Part 1, so I won't spend a lot of time going through that, even though I do have those slides in here. We'll touch on that just to kind of remind us of the background foundational plan, so to speak, and then we'll spend more time detailing the application of this protocol to patients who have autoimmune disease and other chronic inflammatory disorders, because this does apply to lots of different conditions, not simply autoimmune diseases. So this is obviously our Part 2 live webinar, and let's get started with things. So I'm going to go through a few slides. I also have a few slides in here on like what I would consider to be rather basic medical assessment. And the reason that I have that in here is to just remind us and make sure that we put everything in context. A lot of times I teach to students, and I want to remind them that even though we're using nutrition, we're using kind of this functional medicine approach, we still have to be very aware of the potential for major complications. We have to be aware of appropriate immunosuppression when it needs to be employed for the sake of treating patients who have, complications like transverse myelitis and things like that. So having couched it in that way, let's actually start the presentation. So here's our functional medicine matrix. I designed this illustration for the Institute for Functional Medicine a couple years ago. And this helps us just kind of stay oriented to the fact that we have to consider various body systems, and also that we have to consider the way that those body systems work together. So in our case, for example, today we'll be talking about immune and inflammatory balance, but we have to appreciate that that's influenced by gastrointestinal status, by what's going on in the patient's psyche and environment, their hormone and neurotransmitter balance, detoxification status, and very importantly, oxidative stress and energy production. Now, just to introduce this concept a little more, because it's a concept I'm very acutely interested in, we're going to spend a little time talking about mitochondrial dysfunction and how that actually contributes to chronic inflammation. I think for a lot of us, we never thought of that, and we were never taught that, and if you look in most medical books and most even rheumatology books, they don't talk about mitochondrial dysfunction as a contributor to these chronic inflammatory disorders. But in fact, that is the case, so we need to be aware of that. So one of the things I've said before, and I actually said this in 2008, and I was listening to this presentation as I was driving 6 hours to this location, is that we have to consider, rather than just saying, okay, this patient has an immune disorder, what we need to do is consider what are the contributing factors to that immune disorder, and then address each one of those. And so the way I've said it before is if we look at the various contributors and what we even might call sub-contributors to these immune imbalances and autoimmune conditions, then I think that allows us to be a lot more effective when we treat our patients, because rather than looking for a silver bullet that's going to one drug, as if one drug could correct all of this, what if we do a little bit of work here, environmental inputs, nutrition, stress, trauma, etc. What if we do a little bit of work here, help them detox? That's pretty easy. We can balance their hormones and neurotransmitters. We can help them be a little more balanced on a psycho-emotional level. We can address certain structural issues, which is particularly relevant for conditions like hypertension. Less relevant here, but we'll still try to touch on that. And we can address their gastrointestinal status. So that liberates us from having to rely on these, with all due respect for medications, so we don't have to rely on these wonder drugs, as if one drug could restore the entire balance of the immune system. That's physiologically impossible. So why don't we actually look to what's causing the imbalance and then address that? So we have a pretty big task in front of us. The task is to learn a new approach to addressing these clinical conditions. And these are the kind of subcategories or parts of the paradigm that I hope you're all familiar with. All of this is a modification of the material I've been working on for the past 12 years. But when I reformatted my slides earlier this year, I actually understood my material better, and I think this new presentation style will help you get it better as well. So let's keep on making progress here. So this is relevant for patients who have chronic inflammation. And, of course, in clinical practice, we don't see patients who simply have rheumatoid arthritis, typically. We don't see patients who only have fibromyalgia. So we see patients who have diabetes, hypertension, metabolic syndrome, and fibromyalgia. Sometimes they have rheumatoid arthritis on top of that, and sometimes they develop these just systemic, nondescript inflammatory syndromes like mixed connective tissue disease, et cetera. A lot of the information I'm going to talk about here today also is relevant for patients with allergy. I've got a few cases, I believe, that I'll go through, and I certainly have some cases I could verbalize if I recall to do that and if we have time later. So again, the way that I look at a lot of these conditions is just to say that they are manifestations of immune dysfunction and inflammatory imbalance. So that liberates us again from the label that gets applied to patients, and then as if we're supposed to just label the patient with disease X and then follow drug protocol X. When in fact the patients don't even come in with disease X to begin with. What they come in with, as I just mentioned, is they come in with disease X and they've got a little bit of disease A, B, C, and D. So it's never a protocol. It's never as simple as the pathways might represent. In a classic book like the Merck Manual, with all due respect for the Merck Manual, I think it's a nice book. But I think you understand what I'm saying. It categorizes disease as if they were separate entities. But patients don't exist as separate entities. Autoimmune diseases are the third leading cause of morbidity and mortality in the industrialized world, surpassed only by cancer and heart disease. So we definitely have to take these conditions seriously. They're very common. So when I teach this information to students, I do go through some information about risk management and risk reduction. So that's what these slides are about. Any time in this presentation, once you have the recorded version, you can always stop the slides and actually take time to read the information, because we don't have time to go through these word for word, of course. But the general concept of some of these slides is just to practice good medicine, good health care. So I believe, as Victor Herbert once said in an article, treat effectively, document appropriately, and co-manage when you need to. Something to that effect. That wasn't quite right, but I read that article in 1994, so sorry, I'm just trying to recall that. So let's just keep going. Limit of medicine. Let's talk about some of the medical treatments for musculoskeletal pain and inflammation. So when patients receive this non-diagnosis of pain and inflammation, so let's appreciate that as a non-diagnosis. Pain and inflammation are manifestations of immune dysfunction. So to say patient has inflammatory syndrome X, whether we call it lupus or rheumatoid arthritis, that might be comfortable for us, but it doesn't really address the problem. So these patients are usually treated with non-steroidal anti-inflammatory drugs, aspirin, acetaminophen. Then they go to prednisone, methotrexate, sulfasalazine, hydroxychloroquine, and then they go to the biologics, tumor necrosis factor, alpha inhibitors, receptors, et cetera. Now, of course, there's a lot of conversation about stem cell transplant for patients, as if the only option to an immune system that didn't work would be to replace that immune system. A lot of times these patients are then diagnosed with, oops, sorry, so I just received a message that the screen froze for a second, so I'll try to perhaps slow down a little bit. A lot of times these patients are then
diagnosed with either depression or some type of unusual neuropathy, or particularly in fibromyalgia, they're assessed as having something called central sensitization, which I'd be happy to talk about, particularly later if we have more time, because I think there needs to be more controversy about that. And so when they're diagnosed with this aspect of pain, then they're treated with pregabalin, duloxetine, milnacipran, any SSRI or SNRI, because these patients are, by that point, pretty easy to diagnose with depression. And then, of course, there's a 3-step program for opioids, according to the World Health Organization. The 4th step to the 3-part, I should say, World Health Organization protocol is the use of anticonvulsants. So, if we look at these treatments, let's appreciate that none of these treatments actually address the underlying problem. Patients come in with pain and inflammation. They're not coming in with a primary deficiency or inherent need for these medications. So since these medications don't actually address the underlying problem, it's no surprise that they actually don't work that well. Do they reduce certain markers of inflammation? Sure. But do patients actually get better in a honest sense when they're on these medications? A lot of times they don't. When we look at some of these medications like aspirin, most NSAIDs, all of these drugs actually cause intestinal damage. So if we follow the literature, okay. Oh. No, that's fine. Is it just the screen that's frozen? Because otherwise I could just keep talking. Wow. Okay. Well, I'm sorry about that. You want me to disconnect and reconnect? How's that? Are we back on now? All right. I'm getting a little bit of feedback. How are we now? Are we okay? Oh, I'm sorry. You can't see my screen? Okay. All right. Well, let's make sure that we can do that. So you probably get to, oops. There's an article. This is actually an interesting article. We might talk about it later. Sorry. Good morning, everyone. All right. That was me after 4 hours of sleep. Let's see what we can do here. All right, let's go back through this. So what I was just saying, assuming that we're online now, we can always ablate their nerves if they have too much pain. Here's what I want to say about these medications is that they actually make the underlying problem worse in some cases. And again, I'm not totally anti-drug, so I don't want this to come across as such. I've taken prednisone when I had acute inflammatory problem after running into some poison ivy, so I appreciate the application of that drug. I've seen patients go blind with temporal arteritis because they didn't receive prednisone. So, I think we can appropriately respect these medications, but we also need to respect their limitations. So let me see if I can find my mouse, and we'll get back over here. So these drugs, as I was just saying, actually cause increased intestinal permeability. So these drugs cause mucosal damage in the gut. Because of that, they increase antigen absorption from the gut, and that's a major stimulant to systemic inflammation. Prednisone promotes bacterial overgrowth of the small bowel. It weakens the immune system within the gut, and it also causes mitochondrial dysfunction. So we're going to see that actually contributes to the perpetuation of some of these conditions. And even though I think it's pretty well accepted, even by the American College of Rheumatology, that using opioids in some patients, especially patients with fibromyalgia, actually can make them worse. So here's an article that was actually just published showing that sustained rheumatoid arthritis remission is uncommon in clinical practice. So even with the best application of these medications, is it better than doing nothing? Sure, probably so. Does it help prevent some acute complications? Absolutely. But I think we also need to look at how are we managing these people long term other than simply giving them repetitive symptom suppression on a daily basis. What are we doing to actually address the underlying problems here? And I think the protocol that I just reviewed here doesn't address the underlying problems, and that's why patients have to stay on these drugs forever. So, some more topics on risk management here. These are excerpts from a consent form that I used to use and probably still do to a large extent. But basically what I tell patients is I educate them when they have these autoimmune conditions about how they might need to be acutely managed. I try to work with their internist or rheumatologist. I'm happy to do that because some of these patients will need to be acutely immune suppressed at times. So we need to, of course, coordinate care with hospital privileges and some big interventions that we might need to use. Here's some basic assessment considerations: physical exam, laboratory testing, and we'll go through some of those because, again, I just would like us to review it because I know we have kind of a diverse audience. So I'll go through some of those, but again, I'll go pretty quick, and then we'll get into how do we actually manage these patients from this model. A lot of these patients they either have from their disease or they have from their medications or other complications kidney disorders or impaired kidney function. So we have to be aware of assessing their kidney function. Here's a patient I worked with a couple years ago who developed hyperkalemia. You can see her potassium level is 8.5, and it looked like it was a good blood sample. So we have to be aware of assessing kidney function in these patients, and again, that's what I teach my students. But we can also use these markers to actually assess, of course, the success of our plan. If you look at most rheumatology books and articles, at least that I've seen, and maybe this has changed over the last couple of years, but it hadn't changed the last time I saw it. They'll say, for example, that once a patient has positive anti-nuclear antibodies, there's no point in retesting them because they'll always be positive. Well, I've seen patients have positive ANA, and then we treat them, and then they don't have positive anti-nuclear antibodies anymore. And then they discontinue treatment, and then their anti-nuclear antibodies come back. And then I put them back on the plan, and their anti-nuclear antibodies go away. I've seen that come and go with patients over the course of years. So I am very convinced that through the use of versions of this protocol, and everything I've done in the past is actually included within this protocol, except now I do more, that we can get some clinically significant improvement. So here's a case of a man, and I'll just mention him briefly. We'll talk about him again when we look at his other lab results. So let's just remember, this is about a 52-year-old man with 4-year history of rheumatoid arthritis. He so-called failed all the other drugs. And then he came in. I tested his high-sensitivity C-reactive protein, and it was 124. And I got it down to 7.5 within about 5 weeks. And that was without using any anti-inflammatory drugs. And he was a complicated patient because he had metabolic syndrome, hypertension, obesity, and wasn't very diet compliant. He liked hamburgers, and he wasn't too willing to give that up. But when he did give it up, he felt better, and when he went back to eating hamburgers as part of his role of being a football coach, then his rheumatoid arthritis came back. So let's move on from there. If I were to briefly summarize laboratory tests, we can use ESR. Obviously, it's kind of an older generation test. It still has some role, but most of us, I think, use C-reactive protein these days. Ferritin is a marker of iron status. I think the ideal is between 40 and 70, even though we have to appreciate that it's an acute phase reactant. I'm always on the lookout for hemochromatosis in these patients because I think iron overload is underappreciated. Fibrinogen, I like to see that below 250. Anti-nuclear antibody titers, we want to see that below 320 for sure. We can also, these days, we can actually test circulating immune complexes, and we'll talk about that more later because I've got some slides on that. So again, we need to respect these conditions. They can be dangerous, but we can also be effective in our treatment of them, and I think we need to maintain perspective on that. We can treat these conditions effectively. Nothing works all the time in every patient, but not all patients are compliant, and some patients have more complicated diseases than others. I've seen patients with 18 years of autoimmune disease literally cured in like 1 month. So what would cure mean? It means that their disease goes away and it stays in quote-unquote remission for years at a time, and they have no more symptoms. And any abnormal labs become normal. So let's see how we might apply that protocol. Again, rheumatoid arthritis, psoriasis are kind of the prototypes I'm going to follow here. I'm sure I would hope that most people know. And if not, that's okay. But psoriasis these days is considered an autoimmune disease. And hopefully that was decided for appropriate reasons. But when I wrote my rheumatology book back in 2006, I actually proposed then that it should be considered an autoimmune disease. And now I think there's pretty good consensus around that. So again, we can use drugs, but they don't really address the underlying problem. Rheumatoid arthritis, I'm sure we're all familiar with that, so I won't spend a lot of time there. Psoriasis, we're familiar with that as well. I've had some really good success with psoriasis. So let's take a deep breath and start looking at how to address these. So this is a diagram from my book, and at that point I talked about 5 contributors to immune activation. So when patients come into us with pain and inflammation, they're already here at immune activation. And if we look at them from, let's say, a drug-centric approach, then our treatment mostly focuses on how are we going to suppress that inflammation. If we look at this from a functional model or a naturopathic model, then we would look at this patient and say, okay, you have immune dysfunction or immune activation. What's causing that? And at the time I wrote this, back in 2006 and 2007, I had identified 5 major factors. These were pro-inflammatory diet and lifestyle, multifocal dysbiosis, which we'll talk about dysbiosis as we go through the material, of course, psycho-emotional and physical stressors. So just to make sure that I get this point across, because I don't have a slide on it in this presentation, psycho-emotional stress causes an inflammatory response. It causes impaired wound healing. It causes increased intestinal permeability. But it also actually changes the phenotypic behavior of microbes. So there's an emerging field now, which is somewhat oddly titled, but it's called microbial endocrinology. And what it addresses is the relationship between microorganisms and their ability to sense and respond to the stress response of the host. And when they sense that their host is stressed, they actually become more pathologic. They become more virulent. So that's one of the ways that stress contributes to these autoimmune diseases, is that it promotes the development and complexity of dysbiosis. So dysbiosis, for those of you who don't know, just relates to microbes as a cause of chronic health disorders, and in this context, chronic inflammation. So xenobiotics, those are just toxic chemicals. Those can be heavy metals like lead and mercury, which are associated, for example, with atopic dermatitis, or just any carbon-based xenobiotic, pesticides, fumes from paint, carpet, formaldehyde, things like that. A lot of those fertilizers, chemical fertilizers as well, a lot of those are immune toxins, and that's been proven, in my opinion, sufficiently. Hormonal imbalances are very important in these patients. They have at least a 5, and now I think actually a 6-component imbalance that we'll discuss later. So these diseases are complex, but they are understandable. We can apply scientific methods to patient assessment and treatment, even if this means not relying on drugs. We shouldn't let drug treatment be synonymous with scientific treatment. Symptom-suppressing drugs are not the best answer. These patients need a multifaceted approach. A lot of these patients live something that we call the pro-inflammatory lifestyle. They consume diets that are high in sugar. Those cause immune suppression and oxidative stress for at least 4 hours. So it's no surprise that these patients would accumulate this, what we might call body burden of inflammation just through their lifestyle. High-fat foods, especially arachidonic acid, linoleic acid, which was often advocated to lower people's cholesterol levels, actually increases systemic inflammation and breast cancer risk in particular. Saturated fats activate the toll-like receptor 4 and thereby cause a activation of the innate immune system. Fatty acid imbalances are rampant. So most patients who come into your office and my office have fatty acid imbalances, and I think that's quite obvious. So what would make it obvious? Well, let's consider the fact that the historic intake of omega-3 fatty acids has been 7 grams per day throughout human existence. And these days, in the U.S. at least, intake of omega-3 fatty acids is about 1 gram per day. So every day, the average American consumes 6 grams of omega-3 fatty acids per day, less than they should, or at least less than what was historically provided. Vitamin and mineral deficiencies are rampant, especially vitamin D. And vitamin D plays a critical role in immune balance and inflammation. So You can take a patient, for example, who's got vitamin D deficiency. Usually they'll have some marker of inflammation, even if it's just high-sensitivity C-reactive protein. And you give them vitamin D, even if it's a modest dose, and you can reduce their you can reduce, with the use of vitamin D, their C-reactive protein level by about 23%. Well, that provides you direct proof that vitamin D has an anti-inflammatory and immune-modulating role. Allergens, molecular mimicry, and immune complexes, we'll talk about that. A lot of patients eat foods that they're allergic to, whether they know it or not, and in particular, wheat causes immune complex formation, even in healthy patients. So that's why I tell all of my patients they need to get off of wheat. If they're in my office, they're probably in there for pain and inflammation because that's all I see. So I don't care if they've got a wheat allergy or if their celiac disease test was normal. They're off of wheat as far as I'm concerned. Insufficient phytonutrients. Insufficient phytonutrients, a lot of these phytonutrients, of which there are about 8,000, have anti-inflammatory, antioxidant activity. So obviously we want to have our patients consume those. It's a natural anti-inflammatory to eat a high vegetable diet. So let's take advantage of that. Plus, very importantly, and this is critical, underscore critical, when we change our patient's diet, we change the behavior and populations of microbes in their gastrointestinal tract. So when I look at dietary change for a patient, I'm not simply looking at, oh, I need you to eat more fiber and phytonutrients. What I'm trying to accomplish with dietary change is to change their microbial balance within their gut so that they no longer suffer the consequences of immune activation that's actually being triggered by the bacteria in their gastrointestinal tract. It's usually bacteria. Insufficiency of fiber. Fiber helps to get rid of bacteria in the gut. Again, a lot of patients consume foods that promote bacterial overgrowth, such as sucrose, wheat, potatoes, lactose, and dairy. Increased consumption of these is generally associated with increased risk for autoimmune disease, especially inflammatory bowel disease. Dysbiosis. Gastrointestinal dysbiosis is most appreciated, but we've got to think outside of that box. So there are seven different locations for dysbiosis. We'll talk about those later, so I don't have to review it right now. But we've got to think outside of the gut when we think of dysbiosis. Most people don't get enough exercise. Exercise has an anti-inflammatory effect through several different mechanisms. Xenobiotic and toxin accumulation is pandemic, and that's well documented. So that's not just me saying, advocating some conspiracy theory or something like that. Everybody's got toxins. There was an article published in JAMA a couple of years ago showing that 8% of American women had blood mercury levels high enough to actually potentially cause fetal damage. These were women of childbearing age. 8%. Well, and again, they used blood mercury, which, in my opinion, is probably the least sensitive test. It's insensitive for chronic mercury exposure. It's reasonably sensitive for subacute or recent exposure. So even with the least sensitive test, they still found that 8% of American women had mercury accumulation. Well, mercury is also an immune toxin. Mercury promotes immune complex deposition. It promotes glomerulonephritis. It is directly correlated, according to 2 studies that have come out of Germany, with atopic dermatitis. So, and then there's always the factor of emotional stress, which I already touched upon with relation to this new field of microbial endocrinology. So, we want our patients to live a healthy lifestyle. So what I try to do, and the way that I present this in my presentations, obviously in books, is we want to get them off of the Western lifestyle, which actually promotes disease, and we want to get them onto a wellness lifestyle, which has anti-inflammatory benefits, all of which are very well documented. So part of the solution is this 5-part protocol that I put together, which, again, was reviewed in part 1, so I won't spend a lot of time going through diet here, even though I've got a few slides that we'll go through rather quickly. So let's start with number 1, Paleo-Mediterranean diet. So here's what I want. Fruits, vegetables, nuts, seeds, berries, high-quality protein. And within that paradigm, everybody has to customize their diet to avoid allergens. So an apple for one person might be the best thing they could have for breakfast, whereas for someone else, it could possibly cause allergy, so they have to avoid it. I don't do food allergy testing. I just have patients do elimination challenge, and I'm quite happy with that. I've seen patients allergic to chicken broth, of all things. So, we have to be careful with what they're eating. Multivitamin, multimineral, for reasons that will become more clear throughout this presentation. But I want to correct, again, what am I trying to accomplish here? I'm trying to optimize their health. I'm trying to optimize balance. A lot of nutrients have anti-inflammatory effects. A lot of them are immune modulators. Some of them are direct inhibitors of the NF-kappa B pathway, which is a major pathway involved in systemic inflammation. Zinc suppresses NF-kappa B activity. Selenium, coenzyme Q10, several other nutrients, and I may have a slide on that later, but I've certainly reviewed that previously and published on it. Vitamin D, I like to see patients at about 4,000 units, even if they're in Florida, even if they're in Texas. So when I was finishing my last year of medical school in Texas, I started to do a trial of looking at how many of our patients in the rheumatology clinic had vitamin D deficiency. And we measured vitamin D levels in 150, let's say 157 patients, and all but one of them were vitamin D deficient. These were all patients living in Texas, Fort Worth, Texas, 330 days of sunshine per year at a latitude of 32 degrees. So we're still within the sun belt, so to speak. And 99.8% of our patients were vitamin D deficient. So what's the consequence of vitamin D deficiency relevant to this conversation? Chronic pain, chronic depression, contributes to anxiety, promotes increased intestinal permeability. Vitamin D deficiency appears to actually cause leaky gut. Well, that's huge. If we're going to talk about food allergies and dysbiosis, then we have to talk about leaky gut. So then we have to talk about what contributes to that, and vitamin D deficiency seems to contribute to that. Vitamin D is a really potent immune modulator. We'll talk about that later. Combination fatty acids. ALA is alpha-linolenic acid. It comes mostly from flax oil. GLA is gamma-linolenic acid. It comes it's most concentrated in borage oil. It's also available in evening primrose oil, but evening primrose oil has linoleic acid, so it actually has a pro-inflammatory effect from that component. EPA and DHA are from fish oil. That's icosapentaenoic acid and docosahexaenoic acid. And oleic acid, of course, from olive oil, which has potent and clinically significant anti-inflammatory effects, either from the oleic acid itself or the polyphenolics. Probiotics, generally speaking, I think those are good to use because we're trying to restore immune balance and microbial balance. So if you saw part one of my presentation, I talked about this whole paradigm of treating these patients with what we can call nutritional immunomodulation. So what are the components of nutritional immunomodulation? I think I reviewed about 6 different components that we can use, and probiotics are certainly a very strong part of that protocol. So, just to remind you, part of what we're trying to accomplish here also is the induction of T regulatory cells. So, as I reviewed before, and as I'll review again here today, we want to convert those naive T cells, the Th0 cells. We want to block their promotion to Th1, Th2, Th17. We want to have them go into T regulatory cells, I should say, I believe formerly called T suppressor cells, so that they actually do the anti-inflammation for us. So let's look at that later in this presentation. Here's an article that I've written, and you can download this from my website. Five-part nutritional wellness protocol, the supplemented Paleo-Mediterranean diet. That's what I just reviewed for you. Again, the 5 parts are Paleo-Mediterranean diet, which is fruits, vegetables, nuts, seeds, and berries. Multivitamin, multimineral, enough vitamin D to make sure they're adequate, because most multivitamins don't have enough vitamin D. Combination fatty acid therapy, and probiotics. So we talked in the first presentation about an unhealthy diet and how that promotes inflammation. I won't review that here because I had more time earlier to go through more detail. I want to be able to focus on what's new in this presentation. So let's put our patients on anti-inflammatory diets. Fruits, vegetables, nuts, seeds, berries, lean sources of protein, high in phytonutrients, generous bowel movement every day. I've had some patients who have a bowel movement once every 2 weeks. That's not sufficient. Low carbohydrate intake in general has an anti-inflammatory effect. Well, that's interesting. Previously, we reviewed that glucose intake actually causes inflammation, so it only stands to very elementary logic that a low carbohydrate diet would have an anti-inflammatory effect. And there are several reasons and mechanisms to account for that occurrence. One of which, though, very importantly, and I'm going back to microbes, is when we change the diet, we change the microbes. So when we put patients on a low-carbohydrate diet, we are reducing their bacterial load in their gut. One of the treatments for short bowel syndrome in patients who have had intestinal bypass is low-carbohydrate diet. So let's apply that model to what we're treating here. 50% of patients with rheumatoid arthritis have bacterial overgrowth of the small bowel. Somewhere between 80 to 90, and sometimes, according to some studies, more like 100% of patients with fibromyalgia have bacterial overgrowth. So let's go ahead and address